Okay, good morning. This is the third class on evaluation series. Today we will discuss about a stomach mass. We have seen in the last classes we have examined the history and clinical examination. We've already been discussed how, why and how we will say that mass originated from the stomach. And here a patient, 55-year-old man, has come with a stomach mass with symptoms like vomiting, loss of weight, loss of appetite. And on examination there is a mass which is suggestive of originating from stomach. So how will you evaluate it and further manage this patient? That is the content of today's class. So when the patient is there with a suggestive of a stomach mass, maybe it's a malignant mass. Maybe you all know the most common mass arising in a 55-year-old man could be malignant mass. So when we are dealing with a malignancy, there are three types of evaluation we do. That's one is the diagnostic test, second is the staging evaluation, third is the assessment evaluation. So what is the diagnostic evaluation of the stomach mass? Most common mass arising from the stomach is the carcinoma, adenocarcinoma. The other two masses are being common masses are being the GIST as well as the lymphoma. We will towards the end we will briefly discuss about that also. So the most important diagnostic test such situation is the upper GI endoscopy. Okay. But there is a little problem. Can we advise a patient who is having a loss of weight, loss of appetite, suddenly straight away will you do the endoscopy? So when somebody asks that like that, there may be a role for a brief evaluation before endoscopy in the specific patient. Patient may be having low anemia, maybe having cardiac disease, pulmonary disease. So we need to briefly evaluate before the diagnostic test. So there is some change here. And also a patient, suppose he is having a gastric outlet obstruction. A lot of secretions of gastric contents will be pent up inside the stomach. So can we do a direct endoscopy in such patient? There also there is a problem. So this patient may have to be built up for endoscopy, like a nasogastric suction and clearing of the fluids and all this. Okay. So that's some practical issues. So we may have to briefly evaluate this patient before endoscopy. However, the diagnostic test is upper GI endoscopy. You do an endoscopy. What are the things you look for? You look for an ulcer wherever it is, and you take biopsies. At least 6 to 8 biopsies. Okay. The number of biopsies increase, the number of the diagnostic accuracy increases. If you take 6 biopsies, around 70% accuracy. If you take it more than 7, is more than 90% accuracy. So at least 6 to 8 biopsies should be taken. Other points to be noted on endoscopy is the relation with the, I will draw a picture of the stomach here, a relation with the two things. One is the relation with the pyloric antrum and the other relation with the GE junction. Okay. So why it is important is to plan surgical procedure. If it's very close to GE junction, if you don't get a 6 cm clearance here, you may have to think about a total gastrectomy. So you look for the ulcer, the characteristics, biopsy, and the relation with the pylorus as well as the relation with GE junction. That's what the endoscopy will do. Next is EUS have written. If you don't do EUS routinely in every case, if you have the facility, EUS will give you information about the T stage of the disease as well as the end stage. That is perigastric nodes only. T stage means involvement of the stomach mass, stomach wall. In EUS, you can see 5 layers of the GI tract. In stomach, the first 3 layers constitute the mucosa and submucosa. Okay. First mucosa, submucosa are seen in the first 3 layers. The 4th layer, the muscularis propria, and 5th layer, the sclerosa. Okay. So depending on the layer of involvement, you can say the T stage. Which layer it is involved, you can accurately predict the T stage. End stage, yes, the perigastric nodes can be easily seen. Distant nodes cannot be seen. So it is more accurate than CT in case of T stage and early end stage of the disease. So that will be the diagnostic and a little bit of staging. Next we go into these are mainly the staging investigations. USG, transabdominal ultrasound, will give you characteristics of the mass in the stomach. The T staging can be seen, end staging can be seen, and distant metastatic disease also can be seen to some extent, like liver, the ascites, the pelvic mass. All this can be seen with that. But the choice of investigation for staging is CCT. In all cases of carcinoma of stomach, CCT of the chest, abdomen, and pelvis with oral and IV contrast is a mandatory investigation. Okay, so before stage, this is a mandatory for all carcinoma of stomach. So this is the best staging investigation. All the characteristics which we mentioned with ultrasound can be better evaluated. Okay. Though the role of CCT is considered to be more of metastatic evaluation, it also has a role in the T stage and end stage evaluation also. Though we theoretically we say EUA is more accurate than CCT evaluating T stage and end stage. CCT is also very accurate in evaluating the T stage, that is the infiltration to the neighboring structures like pancreas, mesocolon, colon, and end stage, especially the distal lymph node. US can only see the perigastric nodes. If you want to see other distant nodes like the mesenteric node or the parietic nodes and all these, CCT is better than the US. So CCT is a very good, very essential evaluation in the staging this disease. MRI has no specific advantage over the CCT, so CCT is best evaluation. PET scan. What about PET scan? Is it having any role in carcinoma stomach? There is not much role because more than 50% of the carcinoma stomach is PET non-avid. That means they won't take up the PET, the agent. That is the glucose. They won't uptake the F18 glucose. Okay. So it is not very accurate in the evaluating the carcinoma stomach, but there is a role in evaluating a post-chemotherapy status. If you do PET scan, there is more uptake. You may say that there is some avidity there, more activity there. So the role of PET is not much there. Is there any tumor markers in carcinoma stomach? There are no specific tumor markers, but if you do the combination of CEA, CA99, CA74 and CA50, all this combined together, it may help in the staging of the disease. Okay, though there are no specific tumor markers in this case. Next evaluation is the laparoscopy. Laparoscopy as a staging evaluation. The role is that whatever radiological procedures you do, CT, MRI, they cannot pick up small nodules in the peritoneum. Peritoneal metastasis cannot be picked up by any of the radiological evaluation. So laparoscopy has got an important role. These days, many big centers, they do routine laparoscopy before gastrectomy. They assess the peritoneum. Any peritoneal nodules, they take biopsy. Any liver nodules, they take biopsy. They can evaluate the other undersurface of the stomach. If nothing is there, any stage more than T2 or T3, they will take a peritoneal washings and take cytology of this. So any of these are positive, it is considered as a metastatic disease. Okay. So in carcinoma stomach, the treatment depends on stage. If there is any metastasis, curative intent surgery is contraindicated. There is no role. Okay. So laparoscopy has got an important role. The same operating table you can do laparoscopy assess if there is any signs of metastasis, as I mentioned, that is peritoneal nodule, liver nodule, any other pelvic mass, ascites which is positive for cytology. So it's a stage for disease. So laparoscopy is got an important role as well. Then if it's a metastatic disease, the HER2 new receptors is also positive in carcinoma stomach. We need to do. It's already a metastatic disease by any one of the evaluation. HER2 new receptors should be studied as well. Endoscopic mucosal resection. Well, when you do endoscopy, if the size of the ulcer or lesion is less than 2 centimeters, you can resect this margin, resect the entire lesion, and send for biopsy. So that will act as a biopsy as well as a curative disease. We will talk about EMR a little bit later. Okay. So these are the various procedures you do to diagnose and to stage the carcinoma. And the third will be an assessment evaluation. As in any other case, you have to completely evaluate the patient. All systems should be evaluated, all tests should be done, so that the patient is fit for a major surgery. Okay. Accordingly, you can stage the disease according to this, and you should know the various lymph node stages. At least the 16 stages you should know. As undergraduates, you should know at least the 16 stages. There are more stations in the lymph node. There are more lymph node stations for stomach. All these are there. The PG should be aware of that, because further discussion about the treatment of carcinoma stomach will be based on these lymph node stages. Okay. So I will briefly say something. The right one is the right cardiac, left is left cardiac node. 3 is the lesser curvature. 4 will be the greater curvature, which is divided into short gastric, left gastrocapillary, and right gastric. 5 is suprapyloric, 6 is infrapyloric, and 7 is left gastric. You can read it. We will show it to you. So these are the nodes. At least 16 you should know. 16 is again divided into A1, A2, B1, B2. Okay. So all these node stations are important when we talk about the further surgical methods. And this is the T&M staging. This also is desirable to know for undergraduates. Postgraduates should definitely know about it. So this is the T&M staging. This is divided into T1, T2, T3. T1 is divided into TA and T1A and T1B. And T4 is also divided into T4A and T4B depending on the level of infiltration. End stations are divided according to number of lymph nodes, not according to the site of the lymph nodes. Number. N1 is a node 1 or 2 in regional nodes. N2 is more 3 to 6. Okay. N3 is more than 6. N3 is divided into A and B. N3A is 7 to 15, and N3B is more than 16 nodes. Okay. So it's depending on the number of lymph nodes involved. So that is the staging. These two things you should know briefly. Then only we can discuss about treatment. So what according to stage? Suppose the lesion is T1A and TIS and T1A. That is a TIS is the carcinoma in situ involving on the epithelium. Okay. T1A is the involving the lamina propria and the muscularis mucosa. That is TIS and T1A. The treatment option, the more choice of treatment is TMR, that's endoscopic mucosal resection. You can resect it. The principle is that they will have very small, low amount of lymph node metastasis. Okay. So we can, if you resect this tumor endoscopically, you can cure the disease. You can cure. But there is a question there. The choice of treatment is this. But what is the best option? Suppose an MCQ question. Endoscopic mucosal resection, gastrectomy, both are there. Choice of resection may be endoscopic mucosal resection, but that is not the best option. Okay, that's one difference. Best option is always surgical, because in this case also there will be a small amount of lymph node metastasis. Only with radical surgery you can clear it. Okay, this difference you should know. Okay. Now, advanced lesion. So, what is the early gastric malignancy? What is the late gastric malignancy? A tumor which is involving the mucosa and submucosa, irrespective of the lymph node status, we call it early gastric cancer. Anything beyond that we call advanced gastric cancer. So that is it. What are the surgical modalities? Most common surgical procedure is gastrectomy and D2 gastrectomy. So what is D2 gastrectomy? You need a clearance. Suppose there are two types. I am not going to the theoretical details. So there are two types, an intestinal and diffuse type, isn't it? Intestinal type, you need at least 6 cm proximal clearance. Distal clearance we cannot say because the lesion may be in the pyloric antrum. So we cannot go Y of 6, cannot put the criteria for distal clearance. It may be very close to the duodenum. You should get as much clearance as possible, but there is no criteria for distal clearance. Proximally you should get 6 cm in case of 5 to 6 cm in case of intestinal, and 6 to 8, sometimes some people say even 10 cm, at least 6 to 8 cm clearance in case of diffuse type of carcinoma. Okay, that is about the gastric clearance. Then the lymph node clearance is by, classically now these days we always say D2 resection. What is D2 resection? For undergraduates it is okay to understand. There are 3 echelons of lymph nodes, isn't it? One is the level 1, that is level 1 to 6, according to this classification. 7 to 12 is considered the level 2 or echelon 2, and 13 to 16 is considered level 3 nodes. But D1, D2, D3 is not exactly in this pattern, but for undergraduates it's okay to say D1 is equivalent to echelon 1 lymph node clearance, D2 is equivalent to echelon 2, and D3 is level 13 to 16. But that is not exactly correct. For example, I put this here. In distal gastrectomy, you won't dissect entire group. This is for postgraduates. The undergraduates, you don't concentrate much on this part. In distal gastrectomy, you will not be dissecting the level. This is the level 2 and 3A. 3SA. That is the level 2 is the left cardiac group of nodes, and 3 is the short gastric group of nodes. This is not dissected. So what are the groups of nodes dissected in a distal gastrectomy? In D1, level 1, 3, 4B, 4D. 4B means here, that is the left gastrociploid, or D means this is left gastrociploid. So these groups are not, these two groups are avoided. So level 1, 3, 4A, 4B, 4D, and 5 and 6. And 7. 7 group is the short left gastric. So level 1 to 7 is the dissection on the D1 group of dissection, D1 gastrectomy. But in distal gastrectomy, you may not dissect these two groups, the left cardiac and the short gastric group of groups. So there is some difference in the lymph node groups which are removed. In total gastrectomy, all level 1 to 7 is removed in D1 gastrectomy. All groups are removed. What is D2? D1 plus is there in between. D1 plus in distal gastrectomy. In addition to that, you remove the 8A 9 also. 8A 9. So this is described here. You should see here what is the 8A and 9. So level 1 to 7, the 8A and 9 includes the D1 plus. First we talk about distal gastrectomy. So in distal gastrectomy, what is D2, D1 plus and levels 11P and 12. It is a little confusing, but PGs will understand it now. So D2 gastrectomy includes all the nodes from level 1 to 7, excluding this excluding these two groups, up to level 12A. That is the D2 gastrectomy. Okay. Total gastrectomy is a little more simple. D1 includes level 1 to 7. D1 plus includes D1 gastrectomy plus 8A, 9 and 11P. And D2 gastrectomy, whatever which is removed, D1 plus and level 10, 11D and 12A. Okay. If you want PGs little more, I go into detail. This latest classification, the level 10 is not included in total level 10 is not included in the D2 resection. It is called D2 plus resection. In classical D2 resection, you don't remove level 10. That is the splenic hilum. 10 means splenic hilum nodes. That is not removed in classical D2 resection. It is called, if you remove that, it's called D2 plus resection. Okay. That is done in case of greater curvature lesion, which is infiltrating the splenic hilum. Okay. So these are the various resections: D1, D1 plus, D2, D2 plus. Then there is a D3 resection also. If you remove the level 13 to 16, that's called D3. Hope it is clear. That's why I said it is very important to know these numbers. Everything is dependent on the number. This is Japanese classification. D1, D2, everything is depending on the Japanese. Nothing to do with the AJCC. That's American. That's nothing to do with the AJCC classification. Okay. So that is about it. The resection, the primary stomach resection and the lymph nodal clearance. Okay. Now, when will you think about a neoadjuvant chemotherapy? Will you consider neoadjuvant chemotherapy at all? Yes. When you consider when a lesion is more than T2, you always consider a neoadjuvant chemotherapy. So any lesion less than T2, you can go for a upfront surgery. Any lesion beyond T2 or any other extensive lymph node metastasis, you go for a neoadjuvant chemotherapy. Okay. So what are the various options for chemotherapy? There are various regimes are there: EOX regime, ECF regime, then float regime. So many regimes are there. So various drugs are used. So all based on various drugs. Okay. If the patient's performance status is very good, you can go for float regime. What is float regime? This is the 5FU is there, oxaliplatin is there, taxane is there, and leucovorin. There are 4 drugs. Okay. 5FU, leucovorin, oxaliplatin, and taxane. That is doxycycline. 4 cycles are given before surgery. Then you can do the surgery. 4 cycles are given after surgery. Okay. EOX and ECF regimes are there. This is epirubicin, oxaliplatin, and Xeloda, that means capecitabine. This is epirubicin, cisplatin, and 5-fluorouracil. These 3 cycles are given before surgery. Reassess after the surgery with CT scan. If it's operable, go ahead and do the surgery, and 3 more cycles are given post-operatively. Okay. So there is indication for pre-operative chemotherapy. Any lesion beyond T2 or any extensive nodal involvement which you feel it is not possible to do surgery for upfront, you can go for a neoadjuvant chemotherapy. Okay. Now, what is the condition about the G-junction tumor? G-junction. That is a special type of tumor. G-junction tumors are classified according to the Stewart and Staines classification. Okay. This is considered as 1, 2, and 10. Stewart classification 1 to 1. There are 3 markers you should know. The 0 is marked as a G-junction. There is 1 centimeter mark in the esophagus, a 2 centimeter mark on the stomach side, and there are 2 marks 5 centimeter apart on the esophagus as well as stomach. Any lesion which appears more than 1 centimeter away from this G-junction and within 5 centimeters for Stewart type 1. Any lesion which extends 1 centimeter above and extends below 2 centimeter. Within this lesion, the epicenter of the tumor, it's not extension, epicenter of the tumor, we call it level type 2. Type 3 is more than 2 centimeter away, but within 5 centimeter into the stomach side. Okay, this is type 3. Type 1 is classified, it's more like an esophageal tumor, it's an esophageal malignancy. Type 2 is also more likely to be classified and treated like an esophageal tumor, but depends. Type 3 is classified and managed as a stomach malignancy. Okay, so here in 1 and 2, probably you need an esophagectomy. Let's type 3, we may need only a gastrectomy, maybe total gastrectomy. Okay, so these are the 3 types of tumors in the GE junction. Okay, so according to the types of stomach, the GE junction tumor, you accordingly you manage it, whether it's managed as esophageal malignancy or stomach malignancy. Right. Now, this is the whatever we given as a operable. What happens after surgery? You've done the gastrectomy. Will you do any adjuvant therapy? Yes, there is a role for adjuvant therapy as well. If the lymph nodes are positive, you have to give for chemotherapy. But that again depends. After gastrectomy, you need to remove minimum 15 nodes. Lymph nodes should be removed. That then only it will be classified as a D2 resection. Okay. If the lymph node dissection is short of D2 resection, you didn't remove complete lymph nodes in accordance with the D2 resection, postoperatively chemo radiation therapy need to be done. Chemo radiation. Okay. Suppose you have done a D2 resection. You have removed all the nodes in accordance with the D2 resection. Most people prefer to give only chemotherapy. The radiation therapy is avoided postoperatively if you have done D2 resection. Okay. So that is any one of the regimes can be used. Mostly ECF can be used. Or in this, there are other regimes of Ford-Fox regime or CAPOX regime. CAPOX means capacitive oxalic Ford-Fox, you know. So any one of these regimes is used as a postoperative chemotherapy. Okay, so very important. If the lymph node dissection is complete, radiation is better avoided. If lymph node dissection is not complete, you can give chemo radiation. Okay, so that finishes an operable lesion. Okay, either chemo, chemo surgery, post-op chemo, or upfront surgery, plus or minus post-operative chemo radiation therapy or chemotherapy. I hope that part is clear. Okay, now we go into another part which is not operable. Radiation. Suppose already the tumor is metastasis or what will you do? You can give chemo, biopsy is done, chemotherapy with ECF regime. There are certain monoclonal antibodies. That's where it's HER2 new. You can give trastuzumab is one of the drugs which can give, or epidermal growth factor inhibitor, cetuximab. These 2 drugs are used in carcinoma stomach, cetuximab. There are so many other so many drugs are coming up which I am not going to mention now. So many monoclonal antibodies are coming up. These 2 are used: cetuximab, trastuzumab, and any one of chemotherapy is the mainstay. Okay, failure. Another group will be locally advanced. Suppose the tumor is infiltrating the next neighboring organ, like the pancreas, colon, mesocolon. Will you go for a combined resection of these tumor structures also? Yes, you can do with 2 intent. One is with good long-term survival intent. To get this, you should be getting an R0 resection. If you are not achieving an R0 resection by combined resection, you are not R0 resection, that means the results will be as good or as bad as only chemotherapy. But you can get palliation. Okay, but if you want to get a survival benefit, it should be an R0 resection. That means stomach can be resected with part of the pancreas, part of the colon. You can go spleen sometimes. If you get an R0 resection, it's well and good. Less than R0 resection, it is no survival benefit, but only palliation. This lesion is bleeding, obstructing, perforating. Yes, you can do palliative resection, but without survival. So, in unresectable, asymptomatic multi-organ involvement is better managed with the chemotherapy alone. There is no survival benefit. Okay, I think that part is also clear. Now the patient is coming with inoperable lesion called gastric outlet obstruction. That's a very common presentation. We see a patient with a strong antral mass presents with a gastric outlet obstruction. What will you do? If the patient's performance status is not very good, you can do always manage endoscopically with endoscopic dilatation, endoscopic stenting, or laser cannulation. Something if the patient will not stand as surgery. If the patient is fit for surgery, you go and do it. Maybe you can even do a little bit of palliative resection. Sometimes the tumor is metastatic, but the local tumor will be operable, mobile. So we can do a palliative resection, knowing fully that it's only palliation. We are not going to give any survival benefit to the patient. Or we can do a gastrostomy to circumvent the gastric obstruction. Okay. So this is in short about the management of the carcinoma stomach. Okay, we just rush through the management, early operable lesion. So any operable lesion, you go for a surgery. It may be with preoperative chemotherapy followed by surgery, and there is a role for postoperative surgery, postoperative chemo or chemoradiation therapy. A very early lesion, that is TIS and T1A, you can even go for an endoscopic mucosal resection, so that we and the follow up of the patient. Other stages, anything beyond that, you go for a radical surgery. It should be a radical surgery. You should remove all the omentum, circulator omentum, all the lymph nodes, everything we described according to the D1, D1 plus, D2, D2 plus, and D3, whichever resection you are doing. All the lymph nodes should be removed and properly marked, numbered, and sent to the pathologist, so that and properly identify each node, which station you should identify and send it to the pathologist, so that they can properly give you the correct diagnosis and stage of the disease. What is this for overall survival prognosis? The 5-year overall survival is around 25%. So carcinoma stomach is not a good disease to have. The overall survival is, if you do a curative resection, anywhere between 25 to 50% is a 5-year survival. Okay. Early gastric cancer, yes, you have better survival, with more up to 80% in 5-year survival. Okay. Is there any role for prophylactic gastrectomy? Will you ever do a prophylactic gastrectomy to prevent, like a prophylactic mastectomy? Yes, there is a condition called hereditary gastric cancer syndrome. So there is a chance of getting a malignancy, more chance of getting 80% chance of getting malignancy. Such people, you do a prophylactic gastrectomy. That's the gene that is the E-catherine gene, E-catherine mutation is there. So cell adhesion molecule is mutated. Such people, you do prophylactic gastrectomy at the age between 18 and 40. That's the age you do prophylactic gastrectomy. I think that's all about carcinoma stomach. I briefly described 2 more conditions, that is the GIST. A mass, it can present as a stomach mass. The difference between carcinoma stomach and GIST is it is a submucosal lesion or a submural lesion, intramural lesion. So mucosa may be intact. If you do endoscopy, you may see only a bulge. Mucosa will be intact, so biopsy may not be positive. So you need a deeper biopsy to get the diagnosis. So you need a deeper biopsy, and PET scan is a role. It's called syringe-shaped uptake. That is what the description. PET scan has a role there. So once you diagnose, many things, many CD markers are positive. CD117 is there, CD34 is there. DOG, that is detected on GIST 1 type, will be the PGDFR, that is the platelet derived growth factor A type of receptor, will be positive. So you can IHC with any one of these will be positive in case of a GIST. So once you diagnose, the treatment is depending on the size and other factors. Less than 2 centimeters is generally you observe. You don't want to do surgery, except when there are high risk factors like more mitotic figures, that's more than 5 or 50 microfield, or necrosis, or any signs of metastasis or complications. Okay. Unless this, you don't do surgery. Generally, as just more than 2 centimeters, you do surgery. Surgery, the first line. That is, you do achieve R0. There is no clear, no margins, nothing is described. You just achieve margins, good clear margin, R0 resection. No role for lymph node dissection because they don't spread to lymph node. So no lymph node dissection, achieve R0 resection. Any tumor more than 10 centimeter, or there is a rupture of the capsule, you consider it as a malignant and metastatic disease. Okay. Once you rupture the capsule during surgery, it is considered as metastatic, already metastatic. So you need to carefully resect the tumor without breaking the capsule. So any tumor more than 10 centimeter, more than 5 mitotic figures per 50 hyperfield, and tumor site the tumor site towards the small bowel will be more malignant than that of the stomach. So these 3 factors combined, you may consider it as a malignant. More than 10 centimeter, more mitotic figures, a tumor more towards small bowel or large bowel is considered as malignant than stomach. Stomach is considered more benign. And what is chemo? Chemo is not classical chemo. It is about the tyrosine kinase inhibitors. Imatinib is the treatment of choice. Postoperatively you can give. In metastasis, the only treatment we give is imatinib. No role for surgery. Suppose this comes as with metastasis. there is no role for surgery unless there is a complication like a perforation or bleeding. So metastatic GIST is treated exclusively with imatinib. The other drugs used are sunitinib and regorafenib. We can compare these three drugs are used. But is there any role for neoadjuvant imatinib treatment? Yes. Suppose a large tumor which is inoperable to begin with, you can give imatinib for a course of 4 to 12 months, reassess, and then again sometimes it may become operable. If it is not responding to imatinib, you can switch over to sunitinib or regorafenib. Okay. So this is briefly about GIST. I am not going into more detailed discussion about GIST. So treatment is a wide excision without any clear with clear margins, no for lymph node dissection. Chemotherapy is basically by the tyrosine kinase inhibitors, imatinib, sunitinib. Okay. The third is lymphoma. There is very little role for surgery. You take biopsy. That also submucosal lesion biopsy may claim a positive. There is a mucosal ulceration. Once you diagnose as biopsy positive lymphoma, your IHC categorized, and the treatment is chemo and radiation therapy. Our role, surgical role, is only for complications like bleeding, perforation, obstruction, etc. Apart from that, gastric lymphoma, the surgeon's role is nothing. Okay, only biopsy, right? So these are the three main types of epigastric mass related to the stomach. We present routinely to our clinics. This is how we evaluate them. This is how we treat them. This is how we stage them. These are the lymph node stations. So this is how we stage after that. And these are the sections you do given. So to end, these things you should remember. What do you mean by localized cancer? A localized cancer is a TIS and T1A lesion is considered as a localized lesion. When we call it the loco-regional, any lesion with T1B, T4A, M0 with nodal metastasis, maybe N1 nodes, we consider as a loco-regional metastasis. When you say it's metastatic, T4B, anything more than T4B and M1, we call it metastatic disease. TIS and T1A, EMR is a treatment. Okay. T1B, yes, primary, without chemotherapy, you can give upfront surgery. Anything more than T2, you should give a perioperatic chemotherapy, that's perioperatic chemo, surgery, post-operative chemo. So, this is the, in nutshell, about the adenocarcinoma with stomach management. Hope it is very clear for you. Undergraduates may not require many of the things we described in this course, but postgraduates, it is necessary to remember most of the things which I mentioned. Okay? Hope it was useful to you. Thank you.